Hello, my name is Jim Robb. I'm the president of the National Training and Simulation Association, otherwise known as NTSA. For those new to NTSA, we are a nonprofit association dedicated to facilitating dialogue between government, industry, and academia. And our ultimate goal is to provide the best possible training systems and healthcare and education to the warfighters and first responders. We host a portfolio of 9 events each year, the largest of which is iEXCEL in Orlando. Due to COVID restrictions, NTSA, like most other associations, has been forced to go virtual. So we've spent the last 9 months experimenting with the virtual world. And I think today we have another version of innovation, as you'll see. The COVID situation is actually highlighting the value of distance learning and training in virtual environments, in virtual worlds. So we think that this is an opportunity as well, and we're looking for lessons learned as we go. So as a means of increasing the dialogue, as we went through the year, we created this webinar series. We're in our 6th iteration, and we will continue this into next year. Today's webinar spotlights the transformational healthcare simulation industry. It's hosted by the iEXCEL Center in their new Davis Global Center in Omaha, and it's a wonderful new facility. And we congratulate Pam Boyers and the team on getting it up and running. So without ado, let me introduce our moderator for today's event. He's a great friend of NTSA and certainly someone that we respect. I'd like to introduce Daniel Surfete. He's the CEO of Aptima. Daniel has led Aptima to become the premier human performance engineering business in the world. His work optimizes the integration of humans with intelligent technologies in defense, healthcare, aerospace. He's a former iEXCEL keynote from industry, and we appreciated that. And he's the chair of our NTSA webinar planning series. So with that, thank you very much for hosting this today, and I'll turn it over to you, Daniel.
Thank you, Admiral Robb, and hello, everyone. I am absolutely delighted to have been asked to moderate this panel this morning. As scientists, engineers, medical professionals, but just civilians, we're all fascinated by the impact that COVID and COVID-19 pandemic has had on the training, modeling, and simulation industry. We want to know if our technologies have a role. We want to know how the top medical centers in the country have reacted, both in terms of operations, but also in terms of the implications for training. So I couldn't think of a better place that the University of Nebraska Medical Center and iEXCEL to share with us their story. We will have an introduction of our panelists and then a multimedia presentation that will be followed by questions and answers. Many of those questions have been submitted by you, the audience, ahead of these webinars, and we'll do that as time permits. So without further ado, let me introduce the members of the panel. Dr. Kratochvil is a professor and associate vice chancellor for clinical research and chief medical officer at the University of Nebraska Health. He's a professor of psychiatry. He serves as the associate vice chancellor for clinical research at UNMC and the vice president for research at Nebraska Medicine and the chief medical officer at University of Nebraska Health. Dr. Kratochvil also served as the executive director of clinical research for the Global Center for Health Security. Welcome to the panel, Dr. Kratochvil. Our next panelist is Dr. Michael Wadman. He is a professor, staff physician, and chairman of emergency medicine at University of Nebraska Medical Center. He received his medical education at the University of Nebraska Medical Center. He is certified by the American Board of Emergency Medicine as a professional interest in airway management, procedure training, and rural emergency medicine. Our third panelist is Dr. Barnes, Christie Barnes. She is an assistant professor, residency program director in the Department of Otolaryngology. Dr. Barnes received her education at Creighton University, Georgetown University, and the University of Vermont, and she completed her rhinology and endoscopy skull-based fellowship at Ohio State University. And leading our panel is my friend and colleague, Dr. Pam Boyers, who is very well known from many of you in the audience, as really a pioneer in translating all the science of human performance and training and implementing it in a healthcare environment. Dr. Boyers is Associate Vice Chancellor at iEXCEL, and we'll hear that stories today. Her focus is on transforming the education and healthcare professional through the adoption of modeling and simulation, certainly a topic that is of high interest to our audience. She has provided national and global leadership in the concept of creating interprofessional simulation centers around the world. This includes the design, staffing, and operation of these centers, as well as studying the return on investment. So with this illustrious panel, I cannot wait to hear the story they're going to tell us, and I would like to pass the baton to Pam, to Dr. Boyers. Please, Pam.
Thank you, Daniel. And good morning, Admiral Robb. Good morning, our viewers. Thank you so much for joining us today. My colleagues and I are absolutely delighted to be with you as we share how COVID-19 has impacted our training of our healthcare professionals, and it certainly has. But first, since we're joining you from the holographic theater in the Davis Global Center, we thought for fun, and our Chancellor, Dr. Jeffrey Gold, certainly wanted to, that we would take an opportunity to have him introduce you in holographic form. While you don't see him in holographic form, in fact, this is a true holograph. Dr. Gold.
Thank you, Dr. Boyers. It is my pleasure to welcome all of you to the National Training and Simulation Association Training and Special Presentation. UNMC and iEXCEL are grateful for the opportunity to present to our esteemed industry and our military colleagues and to all of our collaborators. Today, each of you will learn about iEXCEL, the Interprofessional Experiential Center for Enduring Learning, a program that aims to transform healthcare education here, across the nation, and around the world. iEXCEL collaborates with industry and with the military to find unique synergies and to push the boundaries of innovation in the worlds of training, simulation, and emerging virtual worlds. Thanks so much for being here today, and enjoy this very special program.
So thank you, Dr. Gold. And I will take over from here. And what I'm going to do is, before our panelists speak, is just set the scene a little bit about what's happening on the UNMC campus and the Davis Global Center. We are actually newly dedicated. We had our formal ceremonies yesterday, but we have been open since January and February 2020, just actually as COVID-19 was hitting the emergency rooms and hitting the news for sure. So just a little bit about the campus itself. We have 6 colleges on campus. We have just under 4,000 students, but we also have graduate students, graduate training programs. And we also have Nebraska Medicine Hospital on campus, which has over 1,000 physicians, in fact, over 8,000 employees. And so the Davis Global Center as a simulation training center actually serves all these disciplines at all levels of training, retraining, and refreshment. And we're very, very poised to move into the future. We are very fortunate. We have a great deal of modeling and simulation technology. And we are glad, I think, to get yesterday a formal dedication ceremonies over and into the next phase of our development. So you will hear from our colleagues about how this center has helped really galvanize them into immediate action. And it has fundamentally been created as a call to action. this call to action was a result of major concerns that were evolving about patient safety. Many of you may know that we actually have an epidemic of avoidable medical errors in this country, some of them leading to death. And in spite of everybody's best efforts, and a tremendous amount of effort has been made, those statistics don't change significantly. So we had to look at new ways to create training methods where people could practice in safe places and become proficient, efficient, and improve their performance. The other challenge we faced as a university and as an educational system is that we felt that health professions education was outmoded, that there were technologies, including virtual and immersive technologies, that could help transform the healthcare professions education and training. And so this is what the Davis Global Center is about. It's truly an interprofessional center where we can train individuals and teams. I think you all know that the best healthcare possible is provided by highly functioning individuals and highly functional teams. And so while we're still early on this journey, this center has been designed to do exactly that, to not only train, but to assess, are we making a difference in training? Are outcomes improving? And can we in fact impact, and we certainly intend to, the safety of patients as they traverse through the healthcare system? I'm going to take you on a very quick tour of the center so that you have the background. Fundamentally, it's 5 levels of simulation training. Each level, though, is distinct, quite distinct in the technologies that it uses. But it's important to understand that these floors or these levels work together. They're synergistic, but they're very, very specialized on their own. I'm going to start with the top floor. The top floor is a surgical floor. It is where we use fresh tissue. There are just simply some procedures and some skills that have to be learned in healthcare using fresh tissue. It has 20 operating room bays. It has coolers, freezers. It has procedure labs. It has places where we can host industry and the military. And it's a true place where not only can people train, but where we can conduct research and partner with others to create new technologies and new procedures and new ways of doing things. So this particular floor is actually already very, very heavily used by all kinds of healthcare disciplines, from PAs to physicians to nurses, and also, of course, with teams. So think about this whole center as I describe it as a clinical test bed from your perspective. We will welcome interactions, collaboration. We know we can't do this alone. So used by all disciplines, right at this moment in time, just to give you a sense, we have already trained over 4,000 learners since opening just for COVID-19 training in March. And then in June, we expanded our training to all others who needed training. But we're just under 4,000 trainees to date in spite of COVID restrictions. We've also learned a lot in this time about how to reach out to the rural communities. But I will take you now to the next level of training. So the 4th floor, the top floor is the 5th floor. The 4th floor is a fascinating floor. It contains 2 virtual hospitals. And these virtual hospitals contain all kinds of healthcare environments, from trauma to pediatric care, to labor and delivery, to imaging. In fact, we have created a place where people can be transferred in a simulated way from home to hospital and back throughout the levels of care. And this floor, with its 2 virtual hospitals, certainly allows us to practice not only skills in very realistic healthcare environments, but the transition of patients as they move from one level of care to the next, which many of you may know is where the majority of communication errors occur. This floor has human patient simulators, very realistic hospital equipment, very hands-on training. It's very tactile, it's very experiential and very interactive. Then we'll move to the next floor, which is the visualization floor. This is more of an experimental floor. This is where we stepped out into the future in a very, very big way. And we have 3D CAD walls. We have a Laser Cave 5, which is a 5-sided virtual environment. We have interactive digital walls, which connect across the state remotely. And we have all kinds of virtual immersive environments where we can do training, research, and discovery, because we're right on the cutting edge of what is possible. It is in its early days of adoption. The holographic theater is, as you can see, quite stunning. We are able to actually make holographs of our faculty or of our mentors and keep them alive for posterity. We're again, just on the sort of front end of exploring what these amazing, amazing technologies can do for us. Critical to this floor is a visualization hub. It's a hub where we have people from many, many disciplines who work together to create the content for healthcare. The content for healthcare that is out there is not always extremely accurate. It doesn't have the acuity that we need. There's not a lot of it out there. So we found we were having to create our own. And because we live side by side with our clinical subject matter experts, we have them readily available to us to help our computer scientists, our medical artists, our graphic designers, and all the different skill sets that we need to create this virtual content. So the next floor is where we have our home unit, where we have our ambulance bay, and where we have also an austere tent environment. And this floor completes our ability to go from home to hospital, throughout the hospital and back in a safe and transitioned way. And again, you can see from the images, it's very well used. It has the home unit has different levels. The ambulance bay is very realistic. And we can work with our first responders, our emergency responders. And the austere tent environment provides a lot of opportunities for Dr. Kratochvil's team to expand their training. So think about this center again as a place where not only do we do training, we do conduct research, but we also need to collaborate with disciplines way outside our healthcare environment so that we can take this beautiful center to its full potential. And at this point, because the next level of the building, the 5th level of the building is under Dr. Kratochvil's, well, it was part of his vision and under his jurisdiction, I'm going to ask him to describe that for you and to tell us how this came about. Dr. Kratochvil.
Great. Thank you, Pam. And thank you to the NTSA for the opportunity to join you all here today. And what you might notice is that the austere tent environment that you saw is a little bit out of place in a lot of the other more refined medical care settings. And that really came about because Pam and her team were open to an opportunity for collaboration and synergy that I'm going to talk a little bit about. If you look back at shortly after 9/11 is really when our Global Center for Health Security story began. In response to that, the University of Nebraska Medical Center and Nebraska Medicine developed a clinical biocontainment unit to serve for individuals who have high consequence pathogens like Ebola. Well, we did in fact activate that unit in 2014-2015 when the State Department repatriated U.S. citizens to our clinical biocontainment unit. And that really developed a robust collaboration with the federal government, with Health and Human Services, Public Health Service, Department of Defense. And what we learned early on is that there was an intense need for training in multiple different ways to handle special pathogens. So we started brainstorming with Pam Boyers and her team And we realized quickly there's a potential for synergy within the Davis Global Center. So what you'll see in here is that we had developed multiple different functionalities within an additional floor, which was initially planned for parking. We convinced Pam and her colleagues that they didn't need that extra floor for parking. And we actually created a floor in collaboration with the Assistant Secretary for Preparedness Response, which contains a clinical biocontainment unit simulation with 6 patient care rooms and a central hub, similar to what you saw in the earlier hospital setting. It also contains an emergency operations center for training of other academic health centers and institutions in how to run an emergency operations center, but also functions as our academic health center's EOC. And we also embedded, just for a little bit of variety, the only federal quarantine program in the country. So we have a 9-11 bed negative air pressure federal quarantine unit within this facility as well, bringing in our expertise, our trainers, our collaborators to work really in synergy with the iEXCEL team. If you look at what happened with COVID-19, that was breaking out, as you know, in January and February of 2020. And our team actually moved into our floor with the Emergency Operations Center and the simulated quarantine unit, biocontainment unit, in October prior to that. So when the State Department decided to repatriate U.S. citizens at the end of January from Wuhan, China, they reached out to us and asked if we would help facilitate and bring those U.S. citizens to Omaha for quarantine. At that point, we leveraged all the resources we had been developing at the Davis Global Center. We used quarantine facilities. We activated the Emergency Operations Center. We had about 100 federal representatives that were helping to manage this. And we used the Biocontainment Simulation Training Center for just-in-time training for our federal partners. It was really a tremendous opportunity to serve the country, to step up and use this training, clinical education center all simultaneously. One of the things that we did early on is we then started pivoting and figuring out how we could apply our learnings, our expertise out into the community more broadly. And so what we did is we started figuring out how we could leverage some of the trainings we had developed with Ebola and other special pathogens, adapt it to coronavirus, to do just-in-time training by video, by external. And we've also developed trainings for the federal government that they're applying both remotely, but as soon as they're able to travel, they'll be using the center here at Omaha. So I think really demonstrates the opportunities that can arise if you really will step up, collaborate, and the synergy can be much more than we could have ever been individually.
Thank you, Dr. Kratochvil. It was an extraordinary time, wasn't it? We were moving into the Davis Global Center at the same time as the federal agents were here. I think there were somewhere between 70 and 90 of them. And the other thing is we had the place absolutely alive with technology installers because we were at last dust-free, and much of the technology couldn't go into the center until we were totally dust-free. But perhaps you could just comment briefly on how you were adopting the visualization technologies for training for COVID-19 with the imagery on the digital walls and the sort of prior preparation.
Yeah, absolutely. So one of the key aspects is as we were doing the training, we're developing training for both contact infectious disease and airborne infectious disease, which clearly has been very relevant for the coronavirus. And so as we've been doing that, using those core principles, we use things such as the graphic demonstrates how to do donning and doffing. What's the correct order of putting on personal protective equipment and taking it off in a very safe way? And that kind of hands-on graphic that we can do both in person here and live and set up competitions with the teams that we've done the training with, but also send out that they can use on their mobile device to be able to remind them in just-in-time training how to put on, how to take off the personal protective equipment safely. So I think that ability to flex quickly, be responsive, particularly in a global pandemic, and implement the resources we had really made a big difference with our federal partners.
Especially since they can also be distributed remotely. So one of the things that has been occurring, a lot of work has been going on in the last few months to take those visuals and put them into the 3D and virtual environments so that they become even more real and interactive. And we're looking forward to the continued journey with you. It's been an extraordinary relationship. Thank you.
Absolutely. And, in upcoming months, we'll have the Department of Defense, we'll have National Disaster Medical System, FDA, Public Health Service, all here training in this facility.
Thank you very much. Well, I'm going to turn to Dr. Wadman now. Dr. Wadman, you've been one of the innovators in simulation and emergency medicine even before the Davis Global Center existed. We had the pleasure of working with you in our prototype hubs. But perhaps you could talk about COVID-19, the impact on training, and you were on that very front line. So we'd love to hear your experience.
Absolutely. Thanks, Pam. It has been a great relationship with iEXCEL when we first started training residents. And before I was chairman of the Department of Emergency Medicine, I was program director and looking for ways to train residents who only had for 3 years with some very critical procedures and critical patient care situations that don't occur all that often, but still our residents have to be prepared for all these things when they complete their 3 years of training. The emergency department interacts with pre-hospital care. They interact with inpatient, with trauma teams. And so obviously team dynamics is one of the things that we focus on in our simulations. We have large-scale simulations out in the community, working with EMS units so that our interface with pre-hospital care is well rehearsed and we know the roles of everyone involved. We also have simulations involving the trauma team and other teams that are involved in time-sensitive diagnoses such as acute myocardial infarction and stroke are two examples where we want the team to function at a very high level, very efficiently in order to get patients the care they need quickly. The other thing that is always a problem with residency training are procedures that don't occur all that commonly. And so we do use simulation for training of our residents in those critical procedures. But we also want our new residents, the novice learners, to be able to succeed in their first application of that skill. And so simulation, I think, is key to providing them the skills needed to succeed on that first attempt. So setting them on a trajectory that is improved for long-term learning. The critical procedures like cricothyrotomy is a procedure that we rarely do. Looking back on my training, 3 years I did one. And so simulation is a key component to training for those rare procedures. COVID-19 really, the way that it impacted us was kind of in both of those areas. The first would be that we were doing some things that were new. The PPE, for the most part, we were familiar with. But there are other things like powered air purified respirators, cappers, and pappers that we had not used commonly. And so we needed to be able to use those safely. And it seems as just a piece of equipment, but there's a team aspect to the donning and doffing procedure. And so our residents were trained in that process so that we could safely use a device that was new to us. In addition, once we're using that new device, it did change the way that we approached patient care, and especially in performing critical procedures. And so iEXCEL was key to allowing us a safe environment to practice those skills with the addition of the new PPE that we were required to use. And really the main thing that changed in our practice was that there are aerosol generating procedures that we needed that higher level of protection for, but it also led to innovations in ways that we provide care. One of those was an intubation box that enclosed the patient and provided a second level of protection for patients for providers who are intubating patients doing a procedure that could potentially generate an aerosol. We tested that in iEXCEL with a substance that fluoresced, using the box and without it, and looked at the differences between the two, and found that the box did contain that droplet nuclei that fluoresced. The one thing that this really led us to understand was that the development of simulation models to replicate these situations is important. And our team developed a model that looked at cough and things that would really lead to generation of aerosolization of secretions. We also looked at ways that our practice had changed. We were no longer using medications in the aerosolized form. We were trying to avoid high flow oxygen, and it led to different teams here at UNMC developing devices that could be used in those situations. And models were used to test them involving iEXCEL that was critical to the development of those devices. Looking towards the future, we're really looking at developing those simulation devices, models that will replicate those situations that we're trying to develop strategies to make them more safe. And so we do have a team within our department now looking at that cough, sneeze model for the simulator so that we can look at different interventions, different devices that may mitigate the risk involved with those highly aerosol generating procedures. Also looking at ways that our patients transition through the emergency department in ways to limit transmission of disease between patients, healthcare providers, and looking at models, computerized models that include algorithms that take into account patient movements within our department, distances needed that would be at risk for transmitting disease, and then looking at our care space and the way that we designate areas for patients who potentially could have infection to be cared for versus other areas that would be for patients without those types of symptoms or risks. And that's kind of what we're looking at right now for future development is those types of models. So the future looks really bright in terms of our interactions, and we're really excited to see what we can do in terms of solutions to these challenging problems.
Thank you, Dr. Wadman. One of the things our staff observed was once your residents and your doctors had practiced donning and doffing, then they found it hard to communicate as teams because of the ability to hear with all the noise going on. And so I know there was a tremendous emphasis on that communication as well, sign language.
Right.
It was another whole era that we were entering, I thought.
Absolutely. Simulation really allows us to optimize our team dynamics, and communication is a key part of that. Adding that level of PPE did make it a challenge, but we were able to overcome it with the simulations.
Yeah. So you led the vanguard because the intensive care specialists followed you, the pulmonologists. So thank you for being such an early and quick adopter, rapid adopter. We've really enjoyed working with you.
Yep. It's been a good relationship.
Yeah. And so we'll move on to Dr. Barnes' story, but I'll never forget the call we had from the ear, nose, and throat physicians, the otolaryngologists. Dr. Barnes and her team suddenly found themselves without elective procedures, correct?
That's correct.
But you have really new and imminent concerns coming onto your horizon, well, not so very close, actually, not just your horizon,
Absolutely.
Because of COVID-19. So we look forward to hearing your story.
Yes, absolutely. Thank you, Dr. Boyers, and thank you for the NTSA for allowing us to present our stories today. My experience with iEXCEL and with simulation is robust. We had, like Dr. Wadman as a program director, I have to train residents in surgical simulation. And this facility, as Dr. Boyers demonstrated in her introduction, is a phenomenal opportunity and a phenomenal space for that very thing. But as Dr. Boyers mentioned, in February and March, suddenly we had found ourselves in the midst of a pandemic. And as you recall, at that time, there was probably millions worldwide of healthcare providers that were suddenly told they needed to perform a procedure that they had never done before, and that's the nasopharyngeal swab. Any of those of you who have been touched either personally or in proxy by this procedure know that there's a lot of fear surrounding it, that essentially the media and social media have actually made worse. I don't know if you've ever perused YouTube or even watched the morning news. You'll see patients complaining that the procedure felt like a lobotomy. which is not ideal. So understanding that the climate around nasopharyngeal swab was already a little bit fraught with fear, and then this technique not being something that was commonly done for most people, we had started to see surfacing within the literature and then within our own community reports of people with it who had been injured during this process. And that's the phone call that Dr. Boyers was referring to. He had said, you know, I think there's an opportunity here for us to collaborate and provide some high fidelity, very targeted just-in-time training for nasopharyngeal swab, a technique that is not familiar to most people that are now forced to do this on a regular basis. So our collaboration started with that phone call, and from there we had just a quick turnaround. Within a week of us approaching the iEXCEL team, we had a very well done training video with infographics and simulated models, and then a full curriculum was implemented and curated by our department. This curriculum then was applied to our first line individuals, and we were able to, with the help of the iEXCEL, run hundreds of super users through this training who went on to impact patients across the state. So we really were able to do so with a quick time. And again, I think the Davis Global Center responded to this cry for help with incredible professionalism and also very swiftly. And we were able to implement this training very quickly. We also identified that, as I mentioned, that there was not just a local need to address some technique issues with the nasopharyngeal swab, but that we can potentially impact those in other locations nationally. So we hosted in this very room a Facebook Live event, which had a much wider reach, in which we described our technique, but also allowed opportunity for providers to ask questions and kind of dispel any myths. I hadn't expected this to become or what came next, but essentially we, with our group here, had been sort of troubleshooting problems with the current simulators that were on the market. We were essentially using these, as you can see on the screen here, these mannequins to do our training. And they seemed to work pretty well, but they were not as anatomically correct as we would have liked. And identifying a opportunity to potentially collaborate with some of the leaders in nasal and sinus simulation, the folks here reached out to one of the industry leaders in that, and that was the Chamberlain group. From that point, we've been working with them to essentially create a high fidelity nasal swab or nasopharyngeal swab simulator. And I'm hopeful that in the very near future, because we're in the final phases of tweaking, that we will have that available to distribute in the very near future. But I think that will be a tremendous asset to hospital systems and those on the front lines performing this procedure on a regular basis.
Dr. Barnes, thank you. Your team was also amazing, but I was fascinated by the variety of professions and disciplines that were actually doing nasopharyngeal swabbing. I know you worked with the National Guard, with pharmacists. Can you talk about that just a little bit before we transition?
Certainly. We ran through several trainings with not just our nursing staff here. We ran a session, like you mentioned, with the National Guard. We also had a correctional facility providers that we were training on this as well. So we had like you mentioned, a variety of individuals who weren't normally asked to provide this type of a procedure that were suddenly found themselves in that situation. So, and we've gotten fantastic feedback about how well that was implemented.
So you're providing very standardized training based on evidence-based approaches, which I think is exactly what we're all about here
That's
today.
exactly right.
So,
Yes.
so
Absolutely.
it's a great journey. Well, Mr. Surfety, Daniel, the only things I want to say before I hand over to you for your question and answer period is we had an interesting time with our visualization hub at this transition. It wasn't just the physicians. Our visualization hub had been that everyone had been hired so that they could create models and information and convert data into 3D in the virtual worlds. So what we actually had to do was switch everybody into production. And you would think that would be an easy switch, but actually it was a totally different skill set. So not only were the physicians and the clinicians, the nurses and others changing the way they had to practice and teach, we were having to change the way we offered the training. So we ended up with doing, I can't remember the number, but it's a large number of live virtual events to not only emergency responders across the state, but to the National Guard, to others, so that we could get remote and distributed training out very, very quickly. But again, it took a very different sort of almost television production skill set. So that's our story. I hope it's what you were wanting to hear, and I'll thank you again for this opportunity.
Okay, thank you very much, Pam. And thank you to Dr. Kratochvil, Dr. Barnes, Dr. Wadman, Dr. Boyers for sharing those stories. They sound like mystery novels. It's extraordinary that you were at the center of all this adaptation that you had to make between just a center that is just set up and the dealing with this crisis management, and you did that in your own way. It's fascinating to me, it's fascinating to the audience that this extraordinary collaboration that has been accelerated by COVID, and the collaboration between the medical profession and the modeling and simulation profession. So we have tons of questions. We have little time, and so I'm going to select a few questions and send maybe the other questions to the team to see if they could answer them after this webinar. I would start with you, Dr. Kratochvil. We heard from Dr. Wadman some examples of how they had to adapt very quickly to team training, to all kind of other decision-making training in the emergency situation. From your perspective, how would you say, what are the positive lessons learned of how COVID-19 healthcare training have changed the overall approach to healthcare training moving forward? Could you give us some insight?
Absolutely. Well, I think as we've seen in our general medical care, that telehealth has really moved forward remarkably out of necessity during this outbreak. I think we've also seen that out of necessity, we've moved very quickly forward with training. So for years, our clinical biocontainment unit staff has gone through exercises and simulations in how to manage patients infected with special pathogens. I think what we've seen very clearly in this outbreak is the importance of doing those kind of simulations with a much broader audience. I think we quickly learned that we needed to train individuals to use the special personal protective equipment and to practice how to perform our daily medical interventions wearing that personal protective equipment. So I think that this reality, again, has moved us forward very quickly, very robustly in the need to be able to simulate, to practice in infection prevention, infection control, and to be able to integrate that in medical education and continuing education. And I think that'll have a lasting impact.
I'd like to add to that the crisis drove innovation by our clinicians, and that there's been nothing in the last 10 years of when I've been in leadership positions in the emergency department that has been really driving clinicians to come up with solutions to these problems. And so now within our department, we're putting together a system by which we can do design thinking and rapid prototyping for devices or solutions to problems as they arise. And so we're at the very early stages of that, but it is the pandemic that's driving those changes.
Thank you. And since you have the microphone, Dr. Wadman, here's a question for you. In Nebraska, as well as across the Midwest, many people seek their care with rural regional providers. What are your perspective on how medical professionals in rural settings, especially, as opposed to urban settings, are using simulation, virtual training tools now and in the future? What kind of unique challenges do they have?
Well, definitely it's a situation for rural emergency medicine where the limitations that I described for our training program are also present. If a physician's practicing in a small rural emergency department, the likelihood of seeing certain rare presentations in patients is very limited. And so simulation of those types of situations, simulation of procedures that are necessary to provide effective emergency care becomes necessary, and simulation is the way that you can accomplish that. Here at Nebraska, we do have Sim Nebraska, which are simulators that are taken to the rural environment where simulations can be done in situ in those emergency departments so that the providers can become comfortable with that critical care application of those procedures in their environment on patients that they don't see all that often. And that's something that we coordinate through iEXCEL. Also looking at ways that we can use virtual reality to train and to maintain skills in rural emergency departments, developing a project that uses augmented virtual reality to train those providers in the use of ultrasound for emergency department patients, where we can do quality assurance, we can do real-time instruction to optimize images and to allow the remote instructor to really tell the person who's at the bedside how to optimize the image, how to place the probe, how to angle, fan, do the things that they need to do to get the information that they need to make a decision at the bedside. So definitely these technologies, iEXCEL as a program, critical to improving care and in the rural environment.
And Mike, I would like to add, so if you look at the Sim Nebraska trucks that go out, 4 of them across the state, they're a straight truck that in the back of it have basically a simulated ambulance bay and a simulated emergency room. So I have a nephew who's an EMT in rural Nebraska, 4 hours from Omaha, and he works in a machine shop, and there is no way he'd be able to take off and come to Omaha and get the kind of consistent training he needs. But having those go out to the rural areas, having their teams be able to train together to do those things that they may only experience once in 5 or 10 years has been invaluable with getting that iEXCEL training and simulation out to the rural communities.
I actually have a story to add, Daniel, if I may.
Yes.
With these, because we had to switch to these live virtual events that went out across the state, I think it's 90% of our first emergency responders are volunteer. Is that correct in Nebraska?
Very high percentage.
Very, very rural state. We actually found that they were watching while they were planting the fields on their mobile devices. They had them propped up, and they were interacting with us from their farms. So it was a wonderful experience. The other thing that I should have said in the introduction, but I wanted to get through it fairly quickly so that we could hear from our clinicians, is that these interactive digital walls are actually distributed across the state. For example, 500 miles to the west in Scotts Bluff. And we can communicate in real time, immediately, visually with those walls. That has been a tremendous statewide effort. We have them in the south, north, and west. We have about 6 or 7 of these walls across the state where we can collaborate, actually all at once if we need to. So it's that was a big initiative and an important one.
Thank you. I would like to ask a question to Dr. Barnes. We are, unfortunately, I have 35 questions here and only the same number of seconds. But Dr. Barnes, if you look at a question about teaching and teaching in the medical school, how has classroom or internet technology enabled or hindered learning specifically during this COVID-19 period, from your perspective?
Sure, great question, because training does need to go on even in the midst of a pandemic. We have a duty to train our future healthcare providers, and so we have had to be creative and change the traditional format of our lectures and our typical didactics to be more of a virtual format. So we've had to move much of our curriculum to the internet and through Zoom and other platforms. So in ways, this has made us allowed our reach to be greater. We found that by everyone in healthcare and healthcare education specifically is facing similar challenges. And so as a result, particularly in the field of otolaryngology, multiple initiatives had been developed where we were able to share lecture content and share information together. And so in ways that really had allowed us to increase our breadth and depth of curriculum opportunities. I think most of us in healthcare, we got into formal training because we enjoy that interaction, or as teachers, as educators, we like to interact with our students. It has made it more challenging from that perspective. I think it's tough to really get feedback from an audience when they're not actually in front of you. And it has really decreased the amount of sort of on-the-cuff questions and on-the-fly mentoring that occurs in medical training. But we certainly have tried to adapt and change over the last couple of months, and some of that I think is going to be here to stay.
Thank you. I'm going to challenge the panelists to a 1 minute quick answer. It's almost a wish list. Everybody in the audience is jumping, saying, "How can we help?"
Oh.
And this is an audience of training, modeling, simulation, education specialists. And could you take just 1 minute or less, each one of you, starting with Dr. Kratochvil and ending with Dr. Boyers, how can this community help?
Yeah, certainly. And it's a great question. And I think the critical issue in my mind that we've seen here with Dr. Boyer's team partnering with us is thinking outside of the box. I mean, if you would have asked 5 years ago how this facility might help the Department of Defense and Health and Human Services and first responders dealing with Ebola and other infectious diseases like that, it's kind of a mind-blowing thing. But we saw very clearly that by thinking outside of the box, by stepping up, by pivoting quickly, applying your resources to the current need, you can make a tremendous difference.
Okay. Thank you very much. Dr. Wadman.
Yeah, I would second that eyes from people that are outside of your discipline are very valuable to answering these challenges. And so anytime we have the opportunity to interact with the industrial engineer or with EMTs, anyone who's outside the emergency department that can really look at a problem we're trying to deal with from a different perspective is something that we highly value and look forward to those types of collaborations.
Thank you. And Dr. Barnes?
Well, I hate to echo all that's been said, but that's what I'm unfortunately going to do, because I really can't say enough about the value that's added to simulation and in this arena with bringing in individuals with different backgrounds. That's where innovation truly happens. And so if you identify a problem, we would love to collaborate with you. This is a group that thrives on change and innovation, and we would love to partner with you.
Thank you. Dr. Boyers, I've been privileged to be your guest at the University of Nebraska and the guest of Dr. Gold a couple of times in the past 2 years. I was literally blown away by two things. First, the vision about how to integrate all these technologies in a way that are science anchored and data driven and evidence based, and at the same time the openness of the medical professionals to play, to just play with and not seeing that just as toys, but as really tools to improve their profession. I will ask you the same question I'm asking others. Many of us would love to collaborate with you. How do we do that?
There's so many ways to answer that, and I know I need to be brief. And I'm not just saying this because you're our moderator, Daniel, but measuring and assessing human performance. Regardless of what is happening right now at this time in our history, with this great center, we have to be able to show a return on investment. We have to be able to demonstrate that all this technology, all this investment, and by the way, it was an extraordinarily public-private partner, the private-public partners, federal partners in this. It behoves us to be able to show that we make a difference, that we not only make a difference in how people learn, that we make a difference in their training outcomes, and that we ultimately make an impact on the clinical care of patients. So what that involves is we actually are installing or have installed behind the walls, and it gets back to the integration of the technology. One of the most critical things in this building is what you don't see, which is behind the walls, and that is the data capture system that we're creating so that we can measure and assess whether what we do makes a difference. Help in that area, I think, is absolutely critical. I think we're only at the front end of that. I think we're doing an honest and decent job, but we've got a long way to go. So that's one of the most critical areas that I think, from my perspective, we need help.
Well, thank you. And I'm sure you're going to hear several requests from the audience precisely about that help. I really want to thank you, Dr. Boyers, and the team, Dr. Kratochvil, Dr. Wadman, Dr. Barnes, as well as the entire team, the production team at the University of Nebraska Medical Center and the Davis Global Center. This is a way to conclude what has been a fascinating hour. I would like to pass the baton to Admiral Robb, who is going to summarize and take us to the next series of webinars. Admiral.
Okay, Daniel, thanks. That was outstanding. And the panel was terrific and very relevant, I believe. So really many, many thanks to everyone. Appreciate Pam. I was there 3 years ago as the sticks were going up across the street, and I look forward to coming back and seeing the finished product. So congratulations. A huge amount of work and an incredible complex way to get all this together financially, as well as to get the support of the state and the federal government. So congratulations to you and the team. NTSA has, as one of our strategic priorities, to identify how modeling, simulation, and training, how this community can affect the problem of patient safety, negative outcomes. This is something that we've taken on for the last 6 years. We have a patient safety working group headed by Dr. Linda Brent, who works for us, and we've certainly seen Dr. Gold actually gave a tremendous patient safety brief presentation 3 years ago at one of our sessions out there. So we take this seriously, and we as a NTSA and the community are on the case. We've brought this to the attention of Congress and at all levels. And for a defense-related sort of association, it's a shame to have someone survive a deployment and then come back and have a negative outcome in a hospital somewhere. So it's all part of the deal. And with my background as aviation, these kind of things can be dealt with. And so we're working hard with this, and we will continue to work at iEXCEL this year with a medical track on this, as well as into the next year with some of our other events. So again, this is a national problem that we are going to help increase the awareness and find ways that our really quality technical human performance people can go after this. I mean, this is a lot of our membership is really good at this sort of stuff. And Danielle is an obvious star in this area, so I'm sure that he can help. So before we go, I'd just like to recognize our webinar team. Dr. Danielle Serpity is the chair, and we appreciate his work. Bob Kleinhampel from SAIC, Ms. Juliana Sly, who's the CEO and of Government Business Results LLC. My staff, Debbie Langelier and Renee Despot, put the back end of this together, and it's a lot of work. So our next webinar will be on November 18th at 1100 Eastern, and it will preview the virtual ITSEC program, and it'll be centerpieced around the program chair and the conference chair. And it's going to highlight the program and the content and the exciting things that we're doing this year. Unfortunately, not in person, but as we transition to a really robust virtual event. So we look forward to continuing that discussion. This discussion that we had today there's a significant medical content there. So please check that event out at vitsec.org and join us at the end of November. So thanks for joining us today. Thanks for having a passion. Thanks for the story and the storytelling that will have effect. And we pray that you stay safe, and we'll see you next month.